Hello and welcome to the webinar Laboratory Networks in Practice, Implications for Pathogen Access and Benefit Sharing. I'm Adam Strabejko. I'm a legal advisor and researcher at the Governing Pandemics Initiative at the Global Health Center, Geneva Graduate Institute. Laboratory networks have been a key topic in the Intergovernmental Working Group on the WHO Pandemic Agreement, tasked with negotiating the Pathogen Access and Benefit Sharing System, PAPS for short. Only when PAPS is negotiated and adopted by the World Health Assembly can the pandemic agreement open for signature and entry into force. The task at hand is complex. Clearer common rules for laboratory networks and a stronger coordinating role for WHO could increase trust in sharing samples by providing certainty around certain benefit sharing arrangements. However, pandemic prevention and response also depend on rapid sharing of samples, and laboratories may face constraints related to capacity and legal compliance. Today's webinar aims to create space for an exchange with experts who work directly with laboratory networks and the practical realities of sharing and coordination. Therefore, we are pleased and delighted to be joined here by the panelists, Dr. Maria van Kerkhove, Acting Director of the Department of Epidemic and Pandemic Threat Management at the World Health Organization, Dr. Cesar Metzger, Head of the Biology Division and Board Member at the Spitz Laboratory, part of the BioHub system, Dr. Konrad Chan, Laboratory Research Co-Lead at the Program for Research on Epidemic Preparedness and Response, PREPARE in Singapore, and Dr. Anne von Gottberg, Laboratory Lead for the Center for Respiratory Disease and Meningitis, National Institute for Communicable Diseases in South Africa. And before we begin, I wanted to mention some housekeeping rules. So this is an academic space. This means we encourage honest and constructive debate. We will start with a round of presentation by speakers, followed by a moderated Q&A. And once in Q&A, I will ask you to put questions in the chat, and I will direct them to the speakers. Finally, please note that the event is being recorded. So the audio and the video will be shared on our YouTube channel. And please pay attention to the chat where members of our team will share further materials. So without any further ado, I give floor to Dr. Maria van Kerkhove. Maria, the floor is yours.
Thank you very much, Adam, and it's a pleasure to be here with all of you, with Cesar, with Conrad and Anne. You've asked me to give a bit of an overview on some of the work that WHO does related to coordinating laboratory networks for pathogens with epidemic and pandemic potential. It's a lot to cover in 10 minutes, and I will do my best. I will say that the slides that I'm using will be happy to make available for others. There's quite some hidden slides in there as well, because I won't have time to go into that detail. And just to thank all of my colleagues up front who helped me pull this together, and for all of the labs that we work with around the world. WHO never does anything alone. We work with partners from around the world, and that's one of the strengths that we have within these global systems. But I want to contextualize first. So WHO manages threats with different dimensions. A lot of us think in the bottom right-hand corner with preventing, preparing, detecting, and responding. But we also have to think of this from a capacities point of view. And this is where laboratory networks are really important with the collaborative surveillance aspect. But laboratories also provide critical data for risk assessment, also for diagnosis to get people into the clinical care pathway. On the upper right-hand corner, we look at different types of threats. And within my department, we look at pandemic threats, epidemic threats, high-threat pathogens like influenza, COVID, Marburg, Ebola, Mpox, bacterial diseases. But there are many other disasters and emergencies that the world is dealing with. So we do this contextually with all of these threats. And then, of course, we look at this from a governance standpoint, and IHR in particular is really important for sharing information, the systems that are required to be able to do this detection, and of course, underpinning that, the financing. And what we are looking at are multiple risks. And one of the things that we're trying to do, this is a map of looking at spillover of pathogens with epidemic and pandemic potential. Again, contextualizing, because we want to have good laboratory systems around the world for early detection, characterization, and the threat is all over the planet. It isn't just in one part of the world. These are maps that we've put together looking at 18 different pathogens. They can be grouped by risk, whether we're looking at transmission type or vector type. And there are different features of this map that we can look at in terms of our readiness and our ability to early detect, but also to look at healthcare systems and reporting capacities. And our overall impact is to strengthen and sustain preparedness. So that's contextually. In addition, we have had enormous increases in testing capacities that started before COVID, but were ramped up during COVID. And this is just an example of COVID-19 testing in the African region. And by April 2020, 94% of countries had testing capacities for COVID. We also see increases in genomic sequencing capacity. The reason I highlight this is because no longer are we in a situation where low-income countries have to ship samples to high-income countries for characterization. That can be done in country. Sequencing can be done in country as well, but we need to maintain those capacities around the world. Now, you specifically asked me to look at, oh, sorry, before I move to that, one of the documents that we have shared recently is looking at not only is it important for sequencing, but to share those sequencing so that analysis can be done. This is a document that's on our website that I just wanted to highlight, looking at the attributes and the principles of data sharing platforms for genomic sequences and why this is important for surveillance of pathogens with epidemic and pandemic potential. We also, within these laboratory networks that we are working on around the world, we are working to ensure that there's strong laboratory biosafety and biosecurity. We have a number of documents that are out that are looking at best practices. This is really important for our laboratory biosafety manual that we're working with countries to make sure that there are secure and safe operations of working with these type of pathogens. And we have a recent resolution in which our member states have asked us to strengthen this around the world. So not only do we have increased capacities, but we also have increased laboratory biosafety and biosecurity needs. Now, I'm going to give you a couple of examples. One is the strongest example that we have of a WHO coordinated laboratory network is the Global Influenza Surveillance and Response System, or GISRIS. This has been in operation for more than 70 years. It includes more than 160 institutions in 131 member states. The map on the right-hand side there will illustrates where these laboratories are. This is institutionalized and it's a functioning global network in terms of capacity for laboratory and disease surveillance, which it integrates multiple respiratory diseases. It started with flu, but it also includes SARS-CoV-2 and RSV, and in some parts of the world, MERS coronavirus. And it's a response mechanism that we use every year for seasonal influenza, as well as for monitoring zoonotic influenza circulation and outbreaks. And there is enormous commitment from member states from around the world with support from international agencies and partners. I have a number of hidden slides that I'm not going to go into about how samples are shared from around the world, but more than 12 million specimens are shared across the GISRIS system each year. And we have 7 WHO collaborating centers. This is really important not only for seasonal influenza, but also for avian influenzas with zoonotic potential. This is a simple map of just looking at where some of the zoonotic influenzas have emerged or where they have been detected in recent years. And it isn't concentrated in one part of the world. We've seen a massive epizootic of zoonotic influenzas, and in particular, avian influenzas. We work very closely using a One Health approach with our partners at WOHA and FAO and also UNEP to monitor and characterize these viruses that are circulating. We also have for influenza we have the PIP framework, the Pandemic Influenza Preparedness Framework, with an objective to improve pandemic influenza preparedness and response and to strengthen the protection against pandemic influenza by improving and strengthening WHO Global Influenza Surveillance and Response System, GISRIS, with the objective of fair, transparent, equitable, efficient, and effective systems and on equal footing for sharing viruses and also for access to vaccines. And of course, there are other benefits as well. But of course, there are many other pathogens that are circulating. So I wanted to give an example of how samples are shared in a non-influenza situation. What you see on the right-hand side is from NextStrain, looking at the phylogeny of SARS-CoV-2 viruses, and this comes from sequences that are shared with GISAID and with other platforms. And you'll see the molecular epidemiology, the analysis here of looking at how this virus has evolved over time. Virus sharing for non-influenza viruses are done according to WHO terms of reference for these laboratory networks. The reason for this sharing is for pathogen identification, characterization, for situational awareness of the ongoing event or the alert, for risk assessment, and for information sharing through WHO products. You will see publicly the disease outbreak news and also rapid risk assessments that we publish. And there are many different benefits for actively engaging with these laboratory networks, including for verified disease elimination, which we've seen for measles and rubella, and also for certification of virus-free status, which we see for the polio virus laboratory network. For SARS-CoV-2, we evolved this work over time. We initially had a reference laboratory network, and which we needed immediately. We built on using GISRIS, but we needed specifically reference lab networks for SARS-CoV-2. And we have recently formalized this into what we call CoVNet, or a WHO coronavirus network, which includes not only lab, but also EPI. And we currently have 56 labs from 37 countries. And these labs cover human health, animal health, and environmental health. And again, we work with our partner agencies at FAO and WOHA to be able to utilize a One Health approach for the detection of SARS-CoV-2 and other coronaviruses. There was some specific examples of what types of objectives in terms of reference that we have. So the terms of reference for CoVNet is to facilitate early and accurate detection of these coronaviruses, to support surveillance and monitoring of global circulation and evolution, to provide timely risk assessment to inform WHO policies related to a range of public health and medical countermeasures, and to support capacity buildings of labs relevant to the needs of WHO and CoVNet, particularly in low and middle income countries. And one of the questions you posed to us are key decisions for sample collection, from sample collection to data sharing. And typically what happens is we have a national reference lab or a lab at a national level or a subnational level, which will confirm the pathogen or the disease of interest. That focal point will notify WHO using under IHR regulations. The Ministry of Health or someone within the government will decide to share virus material or sequence data in publicly accessible databases. And a lot of this is for characterization or further characterization based on the initial diagnosis and the initial detection. Sometimes this is referred to a specialized lab within the country. It could be referred to a WHO collaborating center or regional reference labs for either confirmatory testing or high-level characterization. And this will depend on the capacities in the country. And of course, there's further sharing of information and further sharings of samples depending on the needs, whether this is risk assessments. And ultimately, for influenza viruses and for SARS-CoV-2, we use this information to look at virus evolution, but also to support vaccine composition, which we do for influenza every 6 months for the Northern Hemisphere and every 6 months for the yearly for the Northern Hemisphere and Southern Hemisphere. But these meetings take place every 6 months. We do the same thing for COVID-19 every 6 months as well. I'm not going to go through this, but again, I will give you the slides, but we had some questions to us about what do the terms of reference look like. And this is an example of this. This information is online, so we can actually give you the link to that if you want more detail. But I'm going to quickly go through these. We have many other WHO coordinated laboratory networks. This is one on emerging and dangerous pathogens, EDPLN. We have one for polio, and what I'm trying to illustrate here are where these labs are located around the world. There's an arbovirus diagnostic laboratory network of the Americas, and we are now expanding this to make sure that we have this globally to look at multiple arboviruses like dengue, chikungunya, Zika, or pooch. We have a global measles and rubella laboratory network, and this is a map from last year. You can see where all of the laboratories are located around the world. This is one specifically on HIV drug resistance. This is an older map, but again, illustrating that there are several different types of laboratory networks that are in existence. Lastly, I'll just touch upon this because you have a presentation from SPEETS, but we have initiated a WHO BioHub system, which is a multilateral system for sharing biological materials with epidemic and pandemic potential. We don't include influenza in this because we have GISRIS. We have laboratories that are sharing biological materials on a voluntary basis. They share this with a WHO biohub, and currently we only have one biohub, which is Spitz, but we intend to have multiple biohubs in different WHO regions. That's something that we hope to expand this year. We're aiming to have additional biohubs, particularly in Wipro, but in PAHO, but also in all of the regions. We're just trying to prioritize where we can get this done. And the objective is to promote timely sharing of biological materials with epidemic and pandemic potential. And currently, we have multiple viruses within the biohub system. You can see that on the bottom right-hand side. Many different variants of SARS-CoV-2. We have 3 clades of Npox. We have Oropouche virus. We also have clade C of MERS coronavirus. And then we use SMTA2s and share with qualified entities for non-commercial use. And these are, we've shared, I believe, with more than 75 or 76 different laboratories to use these pathogens for research needs. But this is an example of what we use. And I think I have one more slide of just giving an example of some of the key documents that help facilitate this sharing. Again, I'm rushing through this, sorry, but we have these standardized MTAs, which will outline the rights and obligations of the parties, the benefit sharing, intellectual property, etc. And we do have annexes online so that you can see what these actually look like. But I do want to also highlight that biosafety and biosecurity is really important for the sharing of these materials, not just the use of these materials in labs. And we have a modalities and a checklist for labs that are part of this system. I think I'm going to end there. Sorry, I went through that very, very quickly, but there are more slides in the background that I have, but it's quite a rich area of work. And again, there are many people that are working with us on this. So I'm happy to take questions. I'm sure there will be some later. Back to you, Adam.
Thank you very much, Maria, for this excellent overview of your work with the laboratory networks, including influenza, but beyond influenza. And I also encourage the audience, if they found specific parts of the presentation particularly interesting, to already start writing questions on the chat that I will collect for the later for the later Q&A. And without further ado, I wanted to pass the floor, since Maria already mentioned the biohub, I wanted to pass the floor now to Cesar Metzger from the Spitze laboratory, who will discuss the functioning and the implementation of the biohub in this lab.
Thank you very much, Adam. So I will try to share now my slides. Yeah, it should arrive. Right. So the WHO biohub system, as the name says it, it's under the auspice of the WHO, under the coordination of the WHO. We at Spitz were asked to implement the first lab of this sort. The idea, like my predecessor already said it, is to expand this to a system of biohubs, so to have many laboratories in the different regions of the WHO able to perform these tasks. It's a global system for sharing biological materials with epidemic and or pandemic potential. This is a very important thing to do because we're trying with this in a sense of expanding the response paradigm. So from early detection, early response, we want to go to early detection, early access to the pathogen, early access to information about the pathogen, so that other countries may ramp up their preparation faster, start earlier to work, and in that sense be earlier ready should the pathogen arrive at some point in their own country, or be earlier ready to support, to help out maybe internationally. So in a sense, it's about involving the worldwide back office. So if you have an epidemic starting somewhere, then you can involve rapidly other laboratory capacities outside of this region. So I've made a little pictorial example just to make it a bit more clear. It's the basic principle of a laboratory network. Maybe here a disclaimer: I chose the countries absolutely arbitrarily. This is not a true example. It's just an experiment of thought. And Switzerland is not really to size, because if I put Switzerland to size, you won't see it. It's so small. Exactly. So if something happens, let's say in this region of the world, you have first cases. Of course, the local response will start early. They will try to identify what it is, and if they share quite early material with the biohub. So you send a sample very early to the biohub. The biohub in the background can start to identify or confirm the identification. It can work on the characterization. It can sequence. It can go in depth into the analysis of the pathogen, and it can start to prepare material for sharing to further laboratories who need to start ramping up, on the one hand, their own diagnostic capacities, test the quality of their diagnostic capacity, and start working on research, trying to find solutions to the starting epidemic or pandemic. So there's an early sharing, an early distribution of the pathogen to selected laboratories that respond to the biosafety, biosecurity requirements from the WHO, but also have the capacity and the competence to ramp up rapidly their capacity in testing and diagnostics and research. Now, this allows, of course, if you do that early and fast, it allows for also an early access, after the early access of those partner laboratories, to have an early response, also beneficial for the country or for the region that is affected by the situation, if it's not already spreading further afield, so that you can very early stop the spread through appropriate measures, through appropriate and fast diagnostics, specific diagnostics, and you have the measures that the governments after can take based on proper information on the pathogen. And so at some point, the situation re-normalizes and the system goes back to before the epidemic or pandemic. So early recovery must be the goal, the ultimate goal. So the goals of the WHO biohub system: rapid identification and characterization of the pathogen, risk analysis and further studies, research in possible countermeasures, developing of appropriate and specific diagnostics, implementation of effective safety measures, information of the measures that governments can take in order to respond to the situation. Basically, the world needs a fast-acting and fair global system to deal with new epidemics or pandemics, as we all saw very, very personally in the last 6 years. So basically, this is a simplified graphic from the official graphic that has a lot more detailed information. But the idea is that through voluntary donation of biological materials from countries that are affected by a pathogen to the biohub system, we can start to work on it. There is in the biohub system, of course, always the oversight from the WHO. So the WHO will say if yes or no there's a transfer of material, and after that the WHO biohub system can provide the pathogen to qualified entities. By qualified entities we mean laboratories that are able to use this material for the stated goals. So these recipients, they can receive this material, and they have agreements that are standardized so that it goes very fast. We've reduced with this system the administration and the logistic side of the work to the most efficient minimum that we can have, so that we don't lose time, so that we're efficient, so that it goes fast, or at least much faster than it is the case when you don't have any system in place. Sharing of biological material, especially pathogenic material, can take a long time to clear everything if you don't have any system in place before. And in the case of an epidemic or pandemic, you need to be faster than the spread of the agent if you want to have a chance. So you need to be really efficient. So this is a graphic showing the entire process from the contact by the WHO that will contact. So the country will contact the WHO with a request to send in material. The WHO will contact us as at the moment the only facility participating, and will tell us that something is coming in, and we can then have the signature of the transfer agreement for this material. The transport will be organized safely. It will arrive in Spiez. So in Switzerland, we will do the security checks at the sample receipt. Also look if the samples are intact, if the quality is given. The samples will be processed, so they will be prepared, they will be cultured, they will be made ready for analysis. And then we go into the control part, of course. Quality control is a big point also, that everything works properly. We will reproduce the material to make it available for other laboratories. And finally, or in parallel, we will start with the sequencing, testing the sequence, looking at the characterization of the agents, trying to, after the identification, describe it more in depth. And finally, transfer all the data that is produced back to WHO and or the other platforms that are officially and open to all, like the different sequencing data platforms that are available. And at that point, when other countries express the interest to get a sample in order to start working on those pathogens, they will put their request to the WHO, which will check if everything is according to the plan, and if they have the capacity to receive such samples and are the proper facilities for that. And if everything is fine, they will do the administration part in the background, and we will start to get ready for the sample dispatch with the proper logistical chain with the safety transport. So as my previous speaker mentioned, there are quite a lot of strains of different viruses that are already available in the system that have already been shared with us and also to further partner laboratories. The transparency of the system is such that all these material that we have, they're already published, and they're always getting published as they come in. They're getting published on the website of the WHO BioHub, on the official website of the WHO. You see the address here, so it's clear what we have. We have at the moment 67 entries of 4 viruses available. Here are a bunch of other websites that I've put the links in there, so that when you get the slides, you can check them out again. Okay, so I'm done with my presentation, and
Thank you very much.
As my colleague said before, I'm happy to receive questions afterward.
Thank you very much, Cesar. And also, I see some questions coming in the chat. As I mentioned, I will be collecting them and distributing them in the Q&A, but also if any of the panelists feel at ease with writing responses on the chat and talking about them at the same time, please, you can also have a look at the chat. We encourage an interactive session. Really, this is mostly to gather information about your work. So with that said, thank you very much, Cesar, for this super interesting presentation. And now I pass to Dr. Konrad Chan, who will talk about the perspective of the PREPARE program in Singapore. Konrad, the floor is yours.
Right. So good afternoon, everybody. So thank you for the invitation to speak and share on the laboratory networks within PREPARE. So just a brief introduction to PREPARE. So it stands for the Program in Pandemic Research or Epidemic Response. This is a national program, R&D program, that was set up by the Ministry of Health Singapore to boost Singapore's pandemic preparedness and response to future infectious threats. Essentially, it comprises of 2 components. We have 5 cooperatives which fund specific teams and develop specific expertise. So this ranges from diagnostics, vaccine and therapeutics, analytical disease and behavior modeling, environmental transmission, as well as regional networks. And these 5 cooperatives are supported by 2 PREPARE funded cores, which develop long-term capabilities. And the two cores are the laboratory research core, that's the one that I head, as well as the clinical research and informatics core, and that really focuses on patient recruitment and clinical trials. So the two areas that are particularly relevant to the talk today are the regional network cooperative, as well as the laboratory research. So I'm just going to talk about these two aspects. So for this particular talk, I'll be talking about, as a research program, I'm going to be talking about the lab networks from an R&D perspective. So for the laboratory research core, what we do is we provide high containment expertise. Often during a pandemic, we would expect the pathogens to be RG3. So that often requires a work in a BSL-3 laboratory. And so my team focuses really on working in the BSL-3. And what our work involves primarily is isolation and characterization of pathogens, very similar to what the BioHub is doing, as well as collection and distribution of samples and isolates to laboratories that are within our network or conducting research that are funded by Prepare. In addition to that, we also have ad hoc exchanges with other national health or academic research institutes worldwide to build up a collection of pathogens that are of interest to us. As a pandemic research program, we are primarily focuses on respiratory viruses because we assess those viruses to be of the highest threat in terms of the likelihood to cause a pandemic outbreak. From the cooperative perspective, what the regional network does is build collaborations of outbreak research with countries around the region in Southeast Asia. And we know that Southeast Asia is a particular hotspot for pathogen biodiversity, and it's an area from which there's a high chance that a novel pandemic virus could emerge. We do develop, the regional network develops partnerships with major hospitals and associated research institutes in countries around the region. And currently, they are mainly driving investigation of community-acquired pneumonia cases in these hospitals around the region. And one thing that they have done, which is really particularly useful in helping to accelerate the movement of samples, is to set up material transfer agreements for exchange of clinical samples and isolates with Prepare. And these are signed in advance so that in the event there is a clinical sample or isolate of interest, we do not need to negotiate the legal terms on the spot. It's already been agreed. And the last part of the clinical networks that Prepare is organizing, and this is done domestically, is a National Bio-Level Safety 3 Laboratory Oversight Committee. So this consists of the senior management and safety representatives from all the BSL-3 laboratories in Singapore. So this includes both government, healthcare, as well as academic research laboratories, as well as representatives from Prepare, as well as the Ministry of Health, which is the regulator for the BSL-3 laboratories within Singapore. So by bringing all these stakeholders together, what we do is that during peacetime, before there's a pandemic, we facilitate the exchange of best practices and ensure that there's availability or access to at least a couple of BSL-3s during peacetime. So what happens is that we try to synchronize the BSL-3 shutdown period. So in Singapore, every year, all the BSL-3s need to go through an annual inspection. And when this inspection occurs, that particular BSL-3 is not available for use. So what we try to do is to ensure that the shutdown periods for the different laboratories are synchronized. So there's always a couple of laboratories available in the event that there's a sudden outbreak where work in the BSL-3 needs to be conducted. And during the pandemic, the Oversight Committee facilitates the coordination of the research response and the collaboration, including the sharing of materials across the BSL-3 laboratories. And to facilitate this, we have a national material transfer agreement across all these BSL-3s, as well as with the major public healthcare institutes. So the MTA is a multi-party MTA where all the legal terms have already been agreed, but it's left blank so that when a particular institute wants to transfer material to another institute, they just need to fill up the annex indicating what material is being transferred and what it needs to be used for, and then countersigned by the PIs from both institutes. That way, there needs to be no renegotiation of the legal terms. So how does sharing of material generally occur in our networks? So during an outbreak of a new novel pathogen, usually samples are collected from patients, and then they are sent to a public health laboratory or healthcare institute for initial identification. What happens next is then very critical, and I think it was really alluded to by the presentation on the WHO BioHub, which is then isolation, sequencing, as well as propagation of the pathogen. This may take place in a public health laboratory if it's well equipped, but sometimes this can also take place in a research laboratory like ours, or as well as in biorepositories. And depending on the pathogen, different equipment and different expertise is required. So what you will need for a culture of a bacterial pathogen is different from what you need for the culture of the viral pathogen. And the picture here actually shows an example of viral culture in flask in a CO2 incubator. And this is actually a key area in which the WHO networks can come in, because different countries may have different levels of expertise, different capabilities. And often for viruses, it's quite tricky. You need to find the right cell line to grow it in. And you also need to grow in a certain way such that when you culture it out, the characteristics are not altered during its time in culture. In this area, the biorepositories play a particularly important role in propagating and continue to propagate the pathogen, so that samples of supply of high quality, well-characterized pathogen can be provided to the research labs, which then go on to conduct research that leads to the development of vaccine therapeutics and diagnostics. So as I mentioned, what is shared? Generally, it can be clinical samples, but from a pandemic perspective, sometimes we often expect zoonotic disease, so it might even be animal samples or environmental, such as wastewater or air. Of course, pathogen isolates, that sharing of those is key, but as I already mentioned, culturing and characterization is important, as well as the ability to propagate them. Finally, I think as Maria mentioned in the first presentation, often after sequencing, certain biorepositories specialize in sharing data alone. So like GIS8, they just share or GenBank, the genomic sequences are deposited. And when are these materials shared? The primary case in which is shared, at least in our networks, is mutual agreement by principal investigators. However, from a legal perspective, the owner of the material is typically the host institute. Also, there are often requirements by journals or grant funders that when they publish data or when they do research, that they make available the sequences or the materials on request to the public. And finally, as also shared previously, biorepositories do share their samples or data on request. So ATCC, BEI, GIS8. These are also examples of how material can be shared. So what is the legal process for sharing the material? The main legal instrument for exchange is a material transfer agreement. So I think, as mentioned earlier, BioHub has the SMTA, or standardized material transfer agreement. And the main purpose is to essentially list the material or the data that's being transferred, as well as the purpose, as well as the institute as being transferred to. So these are pretty standardized. It's pretty much take it or leave it. There's not much options for alteration when you're requesting material from a biorepository. However, if you're working with institute to institute exchange, there can be customization to enhance the speed of the exchange. So for example, as I mentioned, within the Prepare BSL3 Oversight Committee, we have pre-approved MTAs where all the legal terms are agreed in advance among all our institutes, so there's no need for further negotiation when we want to transfer a specific material. We also have MTAs with other institutes where we have requested for distributor privileges. So that means what that allows us to do is, within our own country, we can redistribute the material under the same conditions and terms from which we received it with other institutes within Singapore, so that they don't have to go back to the originator. And then finally, the last one of the other customizations that we've done is a reciprocal arrangement. This is pretty common as well, where where we can pass material to another institute, and then that other institute passes material of interest back to us under the same terms. Finally, there's also material transfer agreements where it does not stand alone, but exists as the legal terms and agreements are embedded within a larger agreement. For example, a research collaboration agreement or typically if you're working with pharma or with a commercial company, there'll be a licensing or purchase agreement where the similar terms are embedded within the document. So in terms of for an MTA, what are the obligations on the user, the person who receives the recipient of the material? Typically, there's no onward distribution allowed unless you have distributor privileges, and this gives you a limited, non-exclusive, and non-transferable right of use. It does not mean the ownership is transferred. It just means the right of use is given to you. Also, typically, there's also a restriction that is only for research use only. So the material they receive can't be used on humans, can't be used for clinical diagnostics. And also, there is for non-commercial use as well. However, different MTAs actually define commercial use differently. So some MTAs may define commercial use as no material benefit. Some may only allow non-profit entities or public health agencies to work in it, or others may define no commercial use as the institute is not allowed to receive revenue for the use of the material. So finally, I just want to share some common issues that we have encountered with regards to international transfers of material. And so the first one, the one thing that's very hard to negotiate is the governing law that overseas, which would apply to this MTA. Obviously, both the provider and the recipient would prefer that their own country's law is the governing law. And sometimes this is often dependent a lot on the legal familiarity of both the provider or recipient institute with the legal system in the other country. Of course, geopolitics also plays a role. They may not want a governing law to be there of a country for which the recipient or provider considers not unfriendly. The second issue that we often face with international transfers is export control. So there are several areas that pertain to export control. The first one is the Nagoya Protocol, in which countries have the right to restrict, they can control exports of biological material, and often this is sometimes can be a lengthy process getting approvals from the relevant domestic agency. There's also the end user certificate. This is particularly for risk group 3 pathogens where there is a potential biosecurity risk. So, for example, and this is often dependent a lot from the country from which you're obtaining the sample. And what this often means is that you cannot redistribute the sample within your own country. The shipment has to go directly from the address of the biorepository or the provider directly to the recipient. And the recipient cannot receive on the behalf of other recipients. So what it means often that if your multiple labs within the same country are requesting the same material from a biorepository, that biorepository has to send 4 separate shipments to exactly those 4 addresses. They can't send to one address and then reship them around, because they have to show that the delivery is directly to the address of the recipient. Then finally, there are safety requirements that are often imposed to make sure that the recipient institute has the required biolevel safety tree, usually for risk group 3 organisms, the required biolevel safety tree laboratory to handle this. And the last issue is that often with shipments, this is an issue for the provider, the inability to enforce the agreement in the event there's a breach. Often it's very expensive, even if it's a friendly country, if you're familiar with the legal processes overseas, to go over to the other country and then take the recipient to court in the event that they have breached the MTA. So these are some of the issues that coming up that perhaps the WHO networks may also need to consider when they are setting up their distribution networks.
Conrad, if I may stop you here, and I promise we will, on what seems like a super interesting slide on benefit sharing, but if you could just put it on screen for a second, and I promise we will come back to this in the discussion, if that works for you. And I also see you have a slide on biosafety. So some of these topics may come back in the discussion. If you're okay, we can now pass the floor to our last panelist and then come back to it. Thank you very much for understanding. Maybe if everyone can see the slide and already prepare questions about it, that would be great. And for now, if you could stop sharing, I would like to pass the floor to Dr. Anne von Gottberg.
Thank you. And thank you for this opportunity. I'm just checking if you can see my slides. And is it the right?
We see them, but we don't see them yet in full screen mode.
There. Is that better?
Yes, that works. Thank you.
Thank you. And thank you for the invitation to share some of our experiences. I'm from Johannesburg in South Africa at the National Public Health Institute in South Africa. We've gone through some of the formal networks where funders or organizations might be helping with sharing isolates or specimens. There are informal networks as well, often colleagues. And here I'm showing we're in South Africa, here in the southern tip of Africa, and some of the countries where we've trained and met our colleagues, forged friendships and collaborations and research projects. And there's informal network sharing. What is very important, I think, is for everyone to understand this is all very dynamic. Both the formal and informal networks change, and it's a moving landscape. And to keep that in mind, depending on what you're considering in your agreements and in the legal documents. So for us, it's a two-way street. We would like to share outward and so have assistance when we're struggling to make the diagnosis, receive specimens if a colleague, a neighboring country is also struggling, so receive specimens. And then as soon as some characterization has happened, data, the text information is shared in reports, on web pages, etc. So the phenotypic, serotype, antimicrobial resistance can be shared quite quickly, and so could some genotypic information. And then very importantly, I think for this discussion is the whole genome sequence or more detailed sequences and which databases do they go to, and it's really important to do that. And then still a need to share the specimen and the isolate itself. And for us, the most important premise for this is to help treat individuals who might be sick and make them healthy again, and to mitigate and contain disease outbreaks that may occur at a population level. Our challenges are really with these complex MTAs, the legal, the political ramifications. And what we've done in order to still be able to share urgently and quickly for clinical diagnostic work, we've waived the MTA on some occasions, and also for outbreaks, because there's such a quick need and there's unexpected collaborations or needing to share between countries that you haven't got anything written yet, or you don't have MTAs already signed. And just to highlight that diagnostic work or outbreak investigation work and the definition of what is then research becomes a bit blurred, because as you start investigating in an outbreak and start characterizations and further characterizations, you could argue that it's research. And just to consider that as a complication in your deliberations where you think of what parameters to put down in the agreements. For us, it's really difficult to put a value to all of this. It's almost unknowable. The priority is to save lives and to facilitate the production of vaccines, therapeutics, and diagnostics. And here I'd like to take away the big ogre of big pharma, because there are many, many countries that are now trying to diversify into the pharmaceutical vaccine manufacturing arena. And we need to share with these. And I know this comes into the commercial space, but I think it's really important to consider is that we build this diversification. And for that, we need to share. We need to share isolates, data, and specimens. And just to keep that in mind, it's important that we do this now in peacetime and talk about it. Also, epidemics and maybe not pandemics, but just to highlight the burden that exists when we're trying to share fairly. And this is where I really do think we need reference labs, centralized hubs, and collaborating centers. And just as an example, this was the first sharing of Omicron in 2021. We still had to sign some MTAs that happened quite quickly, but that was because we had the push, the political will at that time. But I'm wary of in the future that this might take much longer, and just how do we try and deal with that and not make it too complex and have to stipulate every little degree of benefit that we might get from something so that we can share quickly. Here we had to share again in the next year, in 2022. And I can tell you now the relief that we felt when we knew that these specimens were arriving in the BioHub, and that the responsibility was theirs now to have the staff and the reagents, the money to share it with other requests, because we were getting all these emails telling us, please, can we share? Can we send it quickly to them? And it's really an incredible burden on the laboratory staff, as well as monetarily trying to put this together. So for us, it was an incredible relief. And then we could start focusing on the outbreak and helping analyze data, do diagnostics in our country. And we were dealing with the national emergency that existed. Another disease, and now I'm just going to highlight 2 bacteria just to highlight some differences and things to consider. Neisseria meningitidis, it's a severe cause of meningitis, often a rapid and fulminant disease, occurs in children that are otherwise healthy and adults that were otherwise healthy, and has an incredible public health impact nationally and internationally. This is the organism that also caused most meningitis, serogroup A meningitis in the meningitis belt before they introduced the serogroup A vaccine. In South Africa, we don't vaccinate routinely for this organism. We had an outbreak of a serogroup W in the early 2000s. We're looking at an increase in 2025 and 2024, worrying what lineage, what serogroup is this? Where else is it occurring? How can we make sure that we're ready for anything that might occur, and do the vaccines that are currently licensed cover some of these strains? This is Africa, the meningitis belt, where we're almost eradicated thanks to all the work that was done with the serogroup A vaccine, but they have other serogroups of Neisseria meningitidis causing outbreaks, meningitis outbreaks in different countries in Africa, and they're unmasking other bacterial pathogens. We want to make sure, and this is what we've tried to think about and consider, is how do we share isolates with, for example, Senegal, who might want to make a rapid meningitis diagnostic kit, so lateral flow assay, where you have to have the organism. Yes, we share the genomes on PubMST, so sequencing data would be available to help with PCRs. But what do you do when you want bedside tests and you need to share isolates in order to make sure that your specimens and your isolates will be covered by these diagnostic tests? For pneumococcus, the vaccine's 13-valent has been introduced in many countries, but they're non-vaccine serotypes and newer valency vaccines that are also being manufactured by smaller players in the world globally. How do we share isolates, make sure that our isolates that are causing disease in the different countries, small countries, big countries, are part of those vaccines? And just as an example, the serogroup meningococcal vaccine didn't consider African serogroup B isolates. And now we've sent isolates trying to share to see would this vaccine work in South Africa, not just based on theoretical information, sequencing information, but also looking at the antigen and the organism. Finally, just diphtheria, that's called the strangling disease. It strangles young children and adults with a pseudomembrane and inflammation. They can no longer breathe and are strangled. It has a high case fatality ratio. Treatment is difficult. Here you see countries that are yellow, orange, and red. That's decreasing vaccine coverage in these countries. That's where they've had diphtheria outbreaks in 2018. Also places with political unrest, refugee camps, just to keep that in mind when you start to think of how do we protect countries, vulnerable countries, in the sharing of specimens. A refugee camp in Africa just last year had a diphtheria outbreak, and some of these epidemic curves that you see from countries in Africa, the y-axis is different. Some of them are in the hundreds, some of them are in the thousands. In South Africa, we have about 10 or 20 at the highest peak of our diphtheria outbreak. But we'd like to know that these strains are shared, data are shared, what's happening with antimicrobial resistance testing, how can we treat these cases, are we keeping on top of the sequences in order to use PCR for diagnosis, and how do we make sure that if there were any vaccine mutant strains causing disease, that we knew about it and could share global information. So you see the reasons for sharing can be myriad reasons, and here in the second bullet I say I can't cover them all in 8 minutes, but in peacetime and during pandemics and epidemics there are different reasons. Case data is much easier to share. It's the text, it's information on our weekly reports, often on the web page, but it's sharing of the sequence data that makes a real difference, and we need to do that safely with some benefits, but do it without too many parameters that we have to control. Specimens and isolates for exactly the same reasons. There needs to be freedom in sharing so that it happens very quickly. The benefits may be indirect, and I think you truly will not be able to quantify or predict the benefits, and please to accept maybe some of that lack of control in this whole aspect. Definitely we need powerful nations and those that have such a strong and loud voice to identify the role of smaller nations in protecting the health of all of us. These are communicable diseases. They know no borders. They will travel wherever they can, and we need to accept that we are a global village. And I'd like to thank you for your attention.
Thank you very much, Anne. And I wanted to thank you, both you and Conrad, who's joining us at a late hour in Singapore, for also highlighting some of the challenges from the lab network perspective, with the legal challenges or capacity challenges, to which I'm sure we will come back in the discussion. But I've seen on the chat, and let us now proceed with the Q&A, and I've seen on the chat that the mention of SMTAs under the BioHub system has raised some attention. So I saw Maria already answered some of the questions on the chat, for which I thank you very much. And I wanted maybe to give you the floor if you wanted to say anything more about it, specifically with the, if I could point to the notion of onward transfer. When you sign an SMTA, if you could tell us a bit more how it works kind of chronologically as well. You mentioned that it's only signed with entities that do R&D for non-commercial purposes. And you also mentioned that WHO will check the biosafety level. And I just wondered what kind of the role of WHO is in signing contracts and checking this biosafety level and coordinating maybe with some of the national authorities regarding biosafety, and coordinating with other partners who are signing contracts. So if you just wanted to elaborate on any points, thank you.
Yeah, thank you. No, so I've been trying to answer some of the questions in the chat as they come through, and I do have my colleague Ioana online who runs the BioHub, so she will correct me if I say anything wrong, because I went through my slides very, very, very quickly, and I do also want to thank Anne and both all the presentations of pointing out challenges, because there's challenges with every single one of these. I think we need to be perfectly clear on this. There is no one laboratory network or one system that is perfect. What we've been trying to do is really, we have a system for flu, but we've been creating a system for everything else. And that's something that the PAB system is negotiating, and how do we do this better? But certainly within the BioHub system itself, first of all, we only have one BioHub right now. And I do want to emphasize that our intention is to have BioHubs in different parts of the world. And I think that's really important because we never envisioned this in one place. And certainly Spitz has been doing an excellent job, but they can't handle everything, nor should they have to. And it's quite expensive to send samples into Switzerland and out of Switzerland. So we want to make sure that there's a good regional approach to this as well. And we're working with our regional offices on that. We do have SMTAs that are used. We use an SMTA1, as we call it, and I'm looking at my slides to help me, from the laboratories that are sharing the specimens into the BioHub. There have been some questions about how we track and trace these and if there's unique identifiers. Please, for those of you who've asked those questions, do look at the website because we do have unique identifiers that are there. But for those that want to use those samples, and again, we have SARS-CoV-2, we have Mpox, we have Oropouche, we have MERS-CoV within the BioHub itself. Those qualified entities have to sign an SMTA2 with WHO, where we are looking at these SMTAs define the permitted uses, and for right now, our SMTAs are covering non-commercial use. They specify how you have to acknowledge where the source of this and how you are using this for different reasons, for research or for publications or for whatnot. There's clarity on intellectual property and liabilities within these SMTAs. This restricts onward transfer. So those who receive this in the labs through the BioHub are not allowed to send those specimens onward. And it formalizes roles and responsibilities. So what we're trying to do is be transparent, with how these specimens can be used. But, we have to abide by all countries have to abide by national laws in terms of how, what is shipped and how they are shipped. We do check on laboratory biosafety and biosecurity, and also depending on the type of research that is being done within those labs themselves, if there are certain types of analysis or certain types of studies that are done that involve animal models, We ask more questions related to this in terms of what is the type of work that's being done, a brief summary of the biorisk management system that's within the system itself, approval of institutional biosafety biosecurity committee, and we ask for documentation on this, approval of animal welfare committee, risk assessment summary and approvals, and copies of permits. So we do go above and beyond if there are certain types of research that are being done. But I also want to specify here that we are not controlling, WHO does not control globally what goes where. We do not control, with the exception of variola virus, what type of research is done. That is up to the national institutes, and there are other bodies that will IRB and things like that. But we do check the laboratory biosafety, biosecurity of the labs to make sure that what is done under safe conditions. I hope that answers the question.
Thank you very much. Yes, it's very helpful. And now maybe if I could ask Cesar to on your side, on the side of the Spitz lab, how do you, once an SMTA is signed, you need to share something. How do you proceed? I assume you can only share when SMTA is signed. There is no equivalent of a shipment notice, if I understand correctly, that is present in the PIP framework, and that would allow for some intermediate sharing before an SMTA is shared. So first of all, is this what I said correct? And secondly, I saw in the chat there are some questions about traceability, and without opening the Pandora box of traceability discussions, I just wanted to ask you about your practice with regards to, I also saw that Maria already provided some helpful answers on that, but from your experience, how do you classify and trace track data, the samples, to make sure that you have control and supervision over the system? Cesar, over to you.
Okay, thank you. Yeah, I'm not sure I understood all the aspects of the beginning of your question, but so basically I want to refer to what Maria said. The system is clearly defined. You have those documentation and these processes that are already from the get-go clear with the signing of the SMTAs. There's the contact with the WHO coordinating the entire exchange between the receiver, but also us, and after that to any potential receiving entities. And I think we are very fast in communication together with the WHO, so that they are always aware of what's happening, and we're also aware of the questions coming in, and what is the state of the process of getting the clearance into the bio hub system. And I think you asked about keeping track, and I think keeping track is a very important aspect of such a system, and it's also one of the main advantages over not working with a system, where if you're working with a lot of bilaterals and things like that, you don't have one overarching tracking system. And here we have a tracking system. As soon as there's a communication about the samples coming in, there will be a sample number, an identifier, a unique identifier that will be given to the sample coming in, and this identifier is communicated to the WHO. They track it in their database, and we know it too. And that way, with this identifier, we can track the sample all the time. And the identifier is also you can, if you go on the website, you even see it. So this is the way I do. I don't know if Maria has maybe a complement to this answer.
No, I think that was great. Just to say, for the onward sharing, the SMTAs are signed between WHO and the lab itself. It isn't signed between Spitz, the biohub itself. The biohub is serving a purpose, as has been explained, but the onward transfer of that is through the SMTA2s, where the terms of reference, where the conditions, the contracts are agreed ahead of time. So thanks for that.
Thank you. That's very useful. And could I just follow up and ask if the identifier would follow in some way the material that is shared onwardly?
The simple answer is yes, it would.
Okay. I don't know, Cesar, if you want to add anything. And Maria also mentioned that for the databases, how it works on the chat. So please have a look at her response. Now I see also some questions on the chat about the engagement of labs and R&D collaborations and capacity building initiatives. And this is my pleasure to come back, as I promised, to Konrad, who can talk a bit more about the benefit sharing experience and also the preparatory regional biorepository network project. Konrad?
Yeah, so thanks for the intro. So in terms of benefit sharing, generally, there are legal terms that are inserted into the MTA. So things like acknowledgement for publications, sharing of IP or revenue that are derived from the research project, and data. These are quite standard in MTAs. Less common, and a capacity building may be an informal agreement. Kind of a handshake, a gentleman's agreement between the institutes, but it also may be a formal thing as part of the RCA. And then finally, the last benefit sharing that is usually seen only in commercial agreements is this thing called right of first refusal. So if the lab develops something that is of commercial value, the provider may have the first right to license whatever's been developed from the laboratory. So these are some of the things that would potentially be included in future MTA so that you can kind of socialize the idea of benefits flowing back to the provider. Yeah. And you wanted to ask me about, so again, sharing on what Prepare wants to do going forward with building the networks. What we're trying to do is that we realize that samples can be difficult to cross borders, especially with the national legislation that controls this. So what we're hoping to do, instead of moving the samples, we want to move the science. We're hoping to build up infrastructure in our region by funding the development of national repositories located in 5 different countries across Southeast Asia, but connecting them virtually through a cloud network so that there is harmonization and sharing of the entire inventory. So from online, it looks like it's a single repository, but the samples are still locally stored. And then bringing people in to work in those countries on those samples rather than having to move the samples around.
Thank you very much. I wanted to ask a similar question to Anne about the benefit sharing component, the capacity building that she briefly mentioned in her slides, but also to extend this question to ask as I'm scrolling through the chat that is very lively, to ask about the need for that Lebo asked about freedom in sharing and the rapidity of this sharing and what it means for when you think about the multilateral system. Anne, I hope this is clear, and if you could comment on this.
I think definitely training and capacity building is definitely a benefit that can be stipulated. I worry that often they become out of date. Things change so much. And I'm not just sure if at that time that type of training would be useful anymore when one stipulates it, and depending on who the partners are. Do you want those manufacturers to train you? I'm not just sure. So I'm thinking in the broader sense, it all sounds good, but I think 3 or 4 years hence, I'm not too sure if that's going to be so useful after you've signed some agreement that says that this needs to happen, and how it needs to happen and to whom it needs to happen. I think the players will have changed. I think freely to share freely, I think is really important. It comes up in some of the questions of who the BioHub should share with, and I think that there should be sharing that is free of favor, of political favors, commercial favors, all these things that we have to grapple with every day. You get emails, and this is what happened during the pandemic. We got emails from different countries, and if I'm here sitting making some judgments on different countries, I think that's where the problem becomes. I need to almost be agnostic to what is happening and who these people are, just to know that they can safely work with the organisms, that they need the organisms, systems. It's not for me to judge why they might need it and what they want to do with it. But I think it needs to at least be discussed, and these decisions need to be taken out of some of our hands. Although I want you to hear from my medical perspective that I think sharing needs to happen extensively, freely, openly, and quickly. And the quickness is because in outbreaks and pandemics, things have to happen quickly. Otherwise, it's of no use. And I do worry that many of these agreements and multilateral signed MTAs, they may not predict who we need to share with at the moment that something happens, and that we didn't think of that one country, this group that needs to share with this group, and we didn't think of this organism that might need to be shared. And so I'm just worrying that there's so much that is unpredictable in our work. Over.
Can I come in on this? Because I just want to highlight
Yes.
some of the points that Anne made, and I think that's really, really critical. So when we are the laboratory networks that we have, the terms of reference that we have are not exclusive. So labs that are sharing with, for influenza, for example, in the GISRA system, we want them shared, the national influenza centers in 130 plus countries are sharing with WHO collaborating centers for characterization. That doesn't restrict where they can send them. They don't have to only send them to a WHO collaborating center. They can share with whoever they want. The same thing for the biohub. I mean, people who have access to SARS-CoV-2 variants can share with others. What we've been trying to do with this system, I just want to clarify here again, we're not a policing system. We are not trying to say who you can share with, what you can do with it. What we're trying to do is make sure that these samples and these specimens are accessible to others. Our requirement is that it's done as a safe way. Our requirement is that it acknowledges the provider and it follows these standard conditions within these SMTAs. But Anne's last point there is really critical. The point, if we have signed so far 76 or so SMTA2s with laboratories for non-commercial purposes. That is certainly not enough for who's going to need that potential pathogen for that next one. So what we're trying to build is a system that is transparent, where where if a sample is identified in one part of the world, it can either be characterized in that country or through a biohub, but is also accessible to others without favor, without politicization. We do have to say, though, I mean, there are rules and requirements about sharing samples worldwide. There are global carriers that will be able to pick up these samples and move them around. And we had a significant issue in the beginning of SARS-CoV-2 about who was even flying. The example that Anne gave with SARS-CoV-2 and the days, I mean, it was hours. It's incredible, right? And that is, again, I want to highlight South Africa here, the willingness to share. There's significant risk for countries to share. One, on the positive side, the global good and being able to get that information out. But there were restrictions that were put on South Africa. We don't want to see that happen the next time. We want countries to be applauded for sharing these types of information. And that's what the PAB system is negotiating. And it's complex. We are giving examples of how different laboratory systems are working. GISRIS is a laboratory system. The biohub is a laboratory system. Conrad is a given example in Singapore and in South Africa, but it is complicated. But what we want to do is make sure that these samples are accessible to more, so that research can be done quickly, so that the development of diagnostics, accurate diagnostics, safe diagnostics, accessible and affordable diagnostics, therapeutics, and vaccines can be used in the time of need.
Thank you very much. This is really important for our audience to have in mind. And if I may follow up, actually, you mentioned also some other laboratory networks, and I just wanted to follow up, use the privilege of the moderator to ask about the role of WHO in different lab networks and terms of reference, if you could give us an example of how it can vary among the different lab networks. Thank you.
So yes, so what we've been doing right now, we've been asked by member states to pull together examples of WHO coordinated laboratory networks. I've presented to member states several times on this, giving different examples, but they've asked us to go through and look at all of them. Now, there's a lot of laboratory networks that are not necessarily relevant for pathogens with epidemic and pandemic potential. So if I just focus on those, what we've done is we've looked, some of them were established a long time ago, like GISRIS, but we've pulled all the terms of reference for those to explain what countries sign up for, how the laboratory networks work. And WHO serves as the secretariat for these coordinated laboratory networks to ensure that we have good geographic representation within the lab networks. That's really critical. And again, I was trying to highlight that capacities have changed over the last 6 years, the last 10 years. No longer do we need to be in a situation where there's only labs in high-income countries. These labs have capacities around the world. We need to continue to support their developments, to maintain those capacities that exist in countries. But we develop the terms of reference. We work with advisory groups to oversee some of that, to make sure that we're looking through and we're thinking through that. There's also terms and conditions that laboratories sign up for. And again, I give you the COVINET example. I can put the link in the chat of what we mean by that. And we facilitate the sharing of those samples. Sometimes we pay for the movement of these samples. It will depend on the country. We don't give money to high-income countries to move samples around, or we try not to. We really focus on low and middle-income countries. If samples need to be moved, we sometimes make those arrangements. And then also working with the labs to ensure that the sequences are shared and further analysis is done on the molecular epi side of things, but also if characterization is done, that there's feedback on what that actually means. The data is used every single day, either for sharing of information to our member states through our information event sites, or we call that our EIS, which goes to all IHR focal points all over the world, whatever the event is. And then we publicly release information in our disease outbreak news. We also conduct rapid risk assessments with this type of information, plus other information, whether we're talking about the signs and symptoms or the clinical care that's needed and any other outcomes. So our role is the secretariat in that, and facilitating that there's good governance within the laboratory networks, that there's terms of reference that exist, that labs are fulfilling their end of the bargain, if you will, in terms of what they signed up for, and just to make sure that it's running. And it's expensive, right? So we also try to make sure in some situations we are providing funding to labs to conduct some of these analyses. We can't do that for everything, and we do have to be selective because we just don't have the funds to be able to do so. But we are grateful for lab like Conrad presented. It doesn't have to be WHO coordinating everything. We certainly don't need to or want to. But what we want to do is have good visibility of where this work is done so that it feeds into a global system, because Anne pointed this out, but we say all the time, these pathogens don't respect borders.
Thank you very much. And I also really recommend everyone to have a look at the chat where Maria and also Joanna from WHO have been providing really helpful detailed answers and materials. Cesar, maybe I wanted to direct a question to you from Tiana, Norwegian mission, from Norwegian government. Is the identifier provided by the laboratory sharing or the biohub? So the identifier that follows a sample.
So when we receive a sample, we provide an identifier that is from the biohub. But as I think Joanna also pointed out in the chat, the database of the WHO follows both numbers. So the original number from the sending lab, but also after, of course, the new number that was assigned. That way, we're very sure that we know from what we talk.
Very good. Thank you. I hope that clarifies the issue. I see a lot of questions about sequence information, and I'm a bit afraid of going into that at this stage. With 10 minutes, we could have had another webinar. But maybe let me firstly, I see one of the topics that's been discussed was the biosafety and the levels, the PSL levels of laboratories. And here I wanted to bring in Conrad, who has mentioned that in his presentation. I wanted to ask you, Conrad, how do you use tools developed by WHO, and how does the certification process work from your experience?
So in Singapore, certification is done by the laboratory using third-party vendors. So they do the certification, but that certification is then provided to the regulator, the Ministry of Health. So this is they are the national regulator. It's not, so regulation is not done by WHO. But we do refer to their manual, the LBM, that Maria mentioned, that's one of our major sources of reference when the regulators take a look at whether the laboratories are adequate. Does that answer the question?
Yes, and is there? So you use the manual provided by WHO, the
Yes,
normative
one of the
guidance of the.
references. Yes, yeah.
Okay,
But nationally, we do have some additional requirements. Yeah. So
I see.
there's some variation from country to country. Yeah.
Thank you very much. That clarifies the topic. I wanted to then move to Anne, and you mentioned also if you could tell us more about the difference between the bacteria and respiratory viruses in terms of your experience with sharing. Could you elaborate on this? Here we mostly discuss when people think of the pandemic, it is often respiratory virus that they have in mind. But I wonder if you could elaborate on the differences, practical differences in terms of sharing when you speak about bacteria as well.
Well, I think it's the reasons why you share, and it's less in a pandemic or in this massive epidemic where influenza, where you're sort of preparing and you want to be preparing at all times for a pandemic. It's more when we're thinking of peacetime prevention, diagnostics, therapeutics, raising antimicrobial resistance, emergence of strains that are not treatable, and it comes to the commercial interests, the vaccine manufacturers, the antimicrobial pharmaceutical manufacturers, and trying to think through. We've had requests from smaller companies trying to enter the pneumococcal vaccine market, or working with meningococcal vaccine manufacturers, trying to get them to consider isolates from other countries that aren't big markets. So it's interesting. It does have some different dynamics, but I think they're interesting dynamics that might be important to think about, because vaccine manufacturers often think of where they want to sell their vaccines, where they're going to make the money, and yet meningococcus, we call them pandemics as the meningococcus moves through countries from China, potentially from North America, from Europe, or from Africa. It moves, and you can trace. It just takes much longer, and therefore it doesn't have this classic feel. But we do talk about it a little as if they were pandemics, and certain strains have got names that are called this strain, this pandemic that has moved across different continents and in different countries. And so I'm just trying to think that the bacteria highlight some aspects that we should be considering, and that we should keep in mind. And very importantly, for diagnostics, therapeutics, and vaccines, we need to support smaller companies, newer companies. And if you put too many tight benefit sharing requirements on them, we're going to starve the market, the ability to have diversification and to have opportunities for smaller countries to get into the market. So I think these are some of the thoughts that bacterial isolates and bacterial sharing come to mind. I'm not sure if they're that helpful for you, but I'm hoping that the differences might help in the deliberations that everyone is having to keep the world safe and to maybe share things equally.
Super, thank you. Maybe as a follow-up, since the sequence information question has been mentioned, just as a clarification to Maria or Cesar. Maria, you mentioned in the chat that the genetic sequence data, sequence information from the BioHub system is uploaded to the public repositories, and of course there's no control after it's uploaded. Is it correct that the identifiers are for samples, and once it's uploaded, it would be difficult to identify it in a public database, and what happens to it?
Well, there's accession numbers that are given to the sequences. And so what our hope is for people who are working with these types of pathogens, that they're sharing sequences with publicly accessible databases. GISAID is one. There are many others. There's GenBank, but there's other national ones that are there. And the importance of that is one sequence alone can give you so much information, but what we want to do is compare those sequences with everything else that is out there to see what changes are and whatnot. And a lot of times this helps understand virus evolution. It helps look at different types of, parts of the pathogen itself. The spike protein for SARS-CoV-2, for example. But for MERS coronavirus, we want to look at the differences between the camel viruses and the human viruses. They give us clues related to transmission. But the accession, there's also metadata you might hear quite a lot about. So there's the sequence itself, which is the series of the nucleotides, but there's additional information that is uploaded in these databases. The date of the sample collection, what type of sample it might be, if it came from a human, if it came from an animal, but there can be other information that's in there. There's no reason why other numbers or identifiers couldn't be added to that as well. I'm not the database specialist, so there are other people that are that, so full disclosure there. And we have people within WHO that are supporting the PABS discussion related to that. But the sequence is one element. There's other data that is needed and is usually shared with that sequence information so that more analysis can be done.
Thank you very much. And again, thank you so much for helping also answer quite fairly technical questions in the chat. And maybe I see that this discussion, has been quite comprehensive. And maybe now I see maybe there is space for 1 minute kind of closing intervention if you want to say something that you didn't have a chance to say either in your presentation or in your responses. Maria, starting from you, would you like to add anything?
No, we are happy here to answer any and all questions. I know that this is a complicated topic. I want to thank those who are supporting the PABS negotiations, for those, that are really in the negotiations in good faith and really, really sitting down there, I mean, in our auditorium, going through that detail. But we're here as support to answer any questions and to try to I guess, get rid of some of the mystery behind some of this. And whenever those questions come, we will make ourselves available to do so, to answer those questions.
Super. Thank you very much for your work and contributions. Cesar?
Thank you very much. Just one last short message, maybe from a lab. Having experienced sharing, I think Anne mentioned it quite extensively before. Having experienced quite a lot sharing material between labs without a system, and how much hassle that can be, how much time that can take. I think somebody asked in the chat, how long does it take when you do an MTA outside of any previous agreed system? Well, it can take weeks to months, sometimes even a whole year before anything happens. If you're depending what's to be discussed and to be cleared. So I think yes, having experienced a well-made system, I can only tell you that it works and that it's I see really the advantages. We leave the advantages, and therefore. Yes, we think that these systems are very efficient and they help out very much.
Thank you very much. And just to answer the question on the chat, yes, the slides and the recording will be shared with the participants. So if you missed anything, any of the detail, you should be able to consult them. Now, Conrad, would you like to add any closing remarks?
No, thanks very much for allowing to share. So I think one very key thing is building the relationship between the exchanging parties. So agreements don't exist in a vacuum. It's really important to right from the start to build strong relationships with partners in different countries. Yeah.
Okay, thank you very much. The importance of also peacetime building of relationships. And Anne, would you like to add anything?
Yes, I think you said once sequences are uploaded, anyone can do what they want with them, but that's not entirely true. They can deal with it from a public health emergency action. They can use the data, but they can't publish on it, and they can't. There needs to be, and I think this highlights my last word, is I think there needs to be a sense of respect and trust in this sharing. And we need to, you can't stipulate all of that. You can't put it all in legalese and put it on a document. We need to respect each other, and we need to trust that our data will be used for what it's needed immediately and urgently, but things won't be stolen from us and taken from us to the extent that other people are then going to publish our data or use our isolates without us staying involved. And I think that would be my last word. Thank you.
Very good. And I hope the PAP system will deliver this trusted system for exchange. As we see, the technical side of it is complicated, but we are here to discuss it. So without stopping you from any further, I would like to firstly thank the team, thank the panelists for their wonderful contributions, their availability, and also thank the team here at the Governing Pandemics. So Diana Jallet, Daniela Moric, Suri Moon, Gianluca Burci, Anna Bezruki, who have contributed to this webinar and its organization. Thank you very much. We look forward to seeing you at other events. And as we mentioned, some of the material will be shared with you and the discussion continues. Thank you.